ऋतु डॉक्टर अशोकन को फोन कर लो।
हाँ जी, ओके सर।
अशोकन को डॉक्टर दत्ता को फोन कर दो।
ओके सर।
हाँ जी सर, कैसे हैं?
So we have couple of minutes to 0 hour before we start officially.
Yes.
Are we live? Are we live, Ritu?
Yes sir. Yes sir. We are live.
So we are live. Thank you everybody. And this is in continuation to our IMA seminars. We are having it regularly. This is our 14th session today in a row, 14th lecture at IMA, which we organize every week on Saturday. So we have couple of minutes before Dr. Ashokan, the Honorary Secretary General from IMA, joins. So just for the knowledge of our guest speaker, Dr. Harsh Mahajan. So we are basically organizing this event every week. Every Saturday we call for a guest faculty. This becomes an official resource for IMA. It goes to all the people in the country, plus it stays on our IMA website forever. So we are, every time we talk an expert and we try to bring out some consensus statement. I have been assigned one job, and on behalf of Confederation of Medical Association of Asia and Oceania, just we are holding on till Dr. Mahajan is free from his talk. हर्ष महाजन का लेक्चर है। नहीं I'm live भैया। So Dr. Harsh Mahajan, what we have the assignment with me is to find out parameters for mortality reduction. So we have been talking to all the specialists, and we are trying to find out the indicators and the markers for mortality reduction. So there are lots of observations we are getting. Say, for example, if we have a corona patient and who has smell and loss of taste, there is no mortality in them. They don't develop severe pneumonia, they don't require oxygen, they don't require hospitalizations. So one marker we have got is that if you have a loss of smell and taste, then mortality is an exception and not the rule. Recovery is the rule. Then we are getting, if you are a woman, in women, if you have diarrhea, then you are a super spreader, then again recovery is the rule and not the recovery is the rule and not the exception. Then we are getting two types of manifestations. One type of a manifestation is pulmonary manifestation. Second is a non-pulmonary manifestations. Most of the patients with non-pulmonary manifestations, we are finding that they are recovering. So they are recovering over a period of time. So we have Dr. Ashokan who has joined, and I'll hand it over to Dr. Ashokan to give a inaugural address, and after that, I will take over. Dr. Ashokan.
Sir, Dr. Harsh Mahajan, Dr. KK, thank you for joining us on this webinar of imaging in COVID. Imaging has emerged as one of the very important dimensions in COVID. As a matter of fact, in many cases, it has been the imaging which has come to the help in diagnosis. I am sure all our members will appreciate this topic. Over to Dr. KK to anchor the episode.
Thank you, IMA. Thank you, Dr. Ashokan. And dear colleagues who are present here and all the persons who are watching this program, which is live on YouTube, Facebook, as well as IMA website. And this is going to be a resource for permanent resource for IMA in their website. So I introduced Dr. Harsh Mahajan, who is the Harsh D. Mahajan as far as radiology is concerned, a past president of Radiological Association of India, and an important resource person in India, both in terms of policies as well as in terms of academics. He has, with his family and his structure, he is working on a lot of AI programs. He is working on a lot of programs at an international level. So there at a place which sometimes back was held by Divan Chand X-ray clinic, which was supposed to be that they create a space. That space which was vacant has been totally taken over by Dr. Harsh Mahajan and his imaging centers. He is a Padma Shri awardee and doing a wonderful job as well as COVID is concerned. Now, purpose of calling Dr. Harsh Mahajan is that we are looking for markers of action where we can quickly act and reduce the mortality. On 12th of February, when China created a new diagnostic tool, and they said that instead of RT-PCR, you use HRCT, and suddenly the number of cases increased. And they came out with a criteria of CT criteria of, they says you don't need to go to RT-PCR. If RT-PCR is not available and if CT is available, you can pick up a COVID on 3rd and 4th day. But at that time, they were not differentiating between COVID and non-COVID. We were not clear that 100% people will get a pulmonary manifestations or not. But now we are getting that large number of people are also getting a non-pulmonary manifestations. There, what is the role of CT? In a CT scan, can we predict mortality reduction? Today, we know that CT has two manifestations. It can be a viral pneumonia, and it can be, in fact, this virus can present with 4 different manifestations: viral pneumonia, 2 viral thrombotic complications all over the body, 3 viral inflammatory process all over the body, and 4 the that means cell which is a cytokine crisis, which is more of a immunological reactions, which can be early and delayed. Delayed means the COVID virus has gone, still a person can have a cytokine crisis on 13th, 14th, and 15th day. So these are the 4 different types of presentations a patient may have. RT-PCR will not tell us which person will develop which complication and which complication will not come. The antigen test also will not tell us. The antibody test will not tell us. Therefore, the role of imaging will come. There was a time when we used to say no imaging because we were not having enough patients. And we knew that in an imaging center, it requires a couple of hours to disinfect. And now in a phase 4, where number of patients are so much, we can have a dedicated CT scan. So therefore, CT scan now has become a reality. So our earlier recommendation that CT only if a must may change, specifically if you are a COVID positive, to follow up to know about your complications. And then today we know that if you diagnose a pneumonia with thromboinflammation on day 3, day 4, a combination of antiviral, which can be remdesivir, a combination of anti-inflammatory, which can be dexamethasone, 6 milligram for 10 days, and a combination of anti-thrombotic, that is low molecular weight heparin. If 3 of them are given together at the earliest marker, which is now going to be told by Dr. Harsh Mahajan, we can boldly say that mortality is an exception, not the rule. Recovery is the rule, not the exception. And when I say recovery is the rule, and that is what we have been told in medicine, we have been taught that every fight till the end, you never know the patient may recover. Still, there will be some mortality, but we face mortality and don't anticipate and think of mortality. Therefore, today, imaging may give us a scenario where it gives us a reason to fight till the end. All my dear colleague, I present to you Dr. Harsh Mahajan. Can I have you unmute?
Thank you very much, Dr. Agarwal. I would like to thank IMA, of which I've been a member for over 30 years, Dr. Ashokan and the other leadership for inviting me to talk about the role of imaging in COVID-19. And as Dr. Agarwal has very rightly said, this is a role that has evolved over time and continuously continues to evolve as we learn more and more about the disease. So I'll just take you through my slides.
Ritu, kindly help him in sharing the slides.
Yes, sir.
Can you see my slides?
No, sir. So please click on share screen.
Yeah, I took share screen and it's there with me. Once. I've got this here, Ritu. I have, you know, my slide is showing on that.
And then niche is, so please share the slide with me on WhatsApp. I'll share, sir.
What should I do?
Send the slide me on WhatsApp. I'll share, sir.
No, I should be able to do it from here, shouldn't I?
Yes, sir, you can.
Yes, it is
Can
coming.
you see it now?
Yes,
Yes.
sir.
You can. Okay, that's good. So, you know, let's talk about imaging. And if you remember, Dr. Agarwal, we had this talk about 2 months ago also.
Yes.
And some things we've learned over time, and I'll be sharing also as to how things are changing. At Mahajan Imaging, we have 9 centers and we do from X-ray to PET-CT. 5 of our centers are standalone and 4 are in hospitals. And out of these 4 hospitals, 3 are in COVID hospitals, where we have, you know, hospitals which have 100, 200 and up to 450 beds for COVID. So we will be sharing our experience of inpatient as well as standalone centers. At the same time, we also have our lab, which is called Caring DX, which is a genomics lab, which which has next gen sequencers, and we've done some NGS for about 130 samples also to look for the genomic profile of the virus and to look for new mutations. And we also do PCR. So we do COVID PCR, RT-PCR for COVID-19. And I'll try sharing our experience. Now, if you look at the cases, as of 3rd of July, yesterday, we had over 1.1 million cases across the world and over 500,000 deaths. At the same time, over 6 lakh people have recovered also. And in India, we've reached over 6 lakhs with a large number, about 60% having recovered, and 2,30,000 odd still active. Now, over these last 4.5 months, there have been hundreds of scientific reports on the clinical features, the epidemiology, the molecular biology, imaging features, and lab diagnosis of COVID-19, and reports of the radiological findings in various stages and comparison with the performance of imaging with RT-PCR, which Dr. Agarwal, you also alluded to, have been made. Also, imaging societies around the world and our own Indian Radiology and Imaging Association have released recommendations for use in imaging and diagnosis of COVID-19. The scope of my presentation, we will talk about imaging concepts that are now more or less well established. We will talk of some recent developments. We will talk of the role of artificial intelligence and where we are trying to work with the government of India. And we will talk about our own experience and our own recommendations. X-ray, and X-ray is really the backbone of imaging of the chest. As we all know, chest X-ray is the radiology investigation which is maximum performed around the world, and nearly 2 billion chest X-rays are performed around the world. And with the advent of COVID-19, that number, I'm sure, has gone up. Although it is less sensitive than chest CT, chest radiography is typically the first line imaging modality used for patients with suspected COVID-19. This is for multiple reasons: for ease of use, for ease of decontamination, and restricting spread of disease. We prefer portable radiography, which can be taken to the patient bedside, which can be taken into the fever clinic. And we, however, need to know that chest radiographs may be entirely normal in early or mild disease. And in some studies of patients with COVID-19 who required hospitalization, that means who had serious disease, only 69% had an abnormal chest radiograph at admission, which increased to 80% during hospitalization. So even with serious disease, at admission, about 31%, and during the stay in hospital, about 20% of patients may have a normal chest X-ray. And findings are most extensive about 10 to 12 days after symptom onset. So this is just to bring home a point that we should not jump readily onto doing a chest X-ray, because in the early stage of even serious disease, 1 out of 3 may be normal. Now, the most frequent findings are airspace opacities, whether you describe them as consolidation, ground glass opacities, whatever name you give it, as long as you're able to recognize the opacity, which you can see very nicely here. And the distribution is generally bilateral and typically peripheral. So they lie near the chest wall. It's typically peripheral and predominantly in the lower zones, though in this case, we have it in the mid zone. And one thing to remember is that pleural effusion is very rare. Only in 1 to 2% of patients you have pleural effusion. So if you have a patient who's come in with significant pleural effusion, the chances are that it may not be COVID-19. Now that's to bring home a point again about the sensitivity of a chest X-ray as compared to a CT scan. On your right, you can see a coronal section from the CT scan, which shows ground glass opacities in the right CP angle region, which when we look at the CT scan, we cannot see at all. It's entirely missed. So even largest lesions may not show up on a chest X-ray. We need to remember, after all, a chest X-ray is a 2D representation of the chest, whereas a CT scan is a 3D representation, and the contrast resolution and hence the sensitivity of a CT scan is manifold as compared to a chest X-ray. So the chest film is insensitive in early disease. And as you can see, this is a chest CT that was done within 1 hour of doing the chest X-ray. Now, we use portable X-rays for serial follow-ups, whether a patient is in the hospital in the ward or is in the ICU. It is portable X-rays that are used for serial follow-ups. And you can see this is 13th of June. On the 15th of June, we see that there's a mild increase in disease, which becomes even more prominent on this chest X-ray that is done subsequently. Again, for temporal progression, this is on the 13th. This is a patient whose chest X-ray has been done on the 27th. So he had a hectic course in the hospital, denser. You can see the opacities have become denser, and on the 28th have become more prominent. And this is when a patient starts to go into ARDS, you start seeing these extensive abnormalities within chest X-rays. This is again another patient, 16th of June. It's a follow-up on the 19th, the 24th, and there's progression. And then you see that there is resolution of the disease, and you can see very nice clearing up of most of the disease on this final chest X-ray that was done before the patient was discharged. And most of these patients receive steroids. And even though the recent study came out about dexamethasone only recently, but I think in most of our hospitals in the country, we've been using steroids regularly, and that may be one of the reasons that we've been able to arrest the disease. We've been able to reduce the overall morbidity and mortality in our patients as compared to the high numbers we saw both in Italy as well as in the early days in New York. Now, at times when a lesion is not seen, and this chest CT and this RASUM image from CT data shows it, it may be worthwhile doing oblique X-ray in the ICU or in the ward, where, since these lesions are subpleural and they are close to the chest cavity, we may be able to unfold it. So this, you can see, is a lesion that was not seen on a routine AP view of the chest, whereas on an oblique view, you are able to unfold it and see it. Just this is from Japan, just another technique that may be used. A word about point of care ultrasound, and some people are really fond of using this. In our experience, it has been used very, very less. In most instances, a chest X-ray suffices, and where it does not, and the patient is going down, or we want to triage, then a chest CT is used. But this can also be used point of care, portable ultrasound. It's not a sensitive or a specific modality, but has been shown to be useful to monitor progression of disease in patients with hypoxemia and hemodynamic failure. It may be superior to standard chest radiography, as the lesions are predominantly peripheral and subpleural in location. So you can get a window which doesn't need to actually go through normal lung parenchyma, as these lesions are peripherally located. The advantage, of course, is ease of use, and it's inexpensive, it's repeatable, there is no radiation exposure, and many people are fond of using this. Now, the findings are that there are multiple B lines, irregular thickened pleural line with scattered discontinuities, subpleural consolidations can be picked up very, very easily. Alveolar consolidation, which is seen in progressive disease, can be seen, and restitution of airway during recovery with the reappearance of bilateral A lines can be seen very well. So it is a good tool, only one has to go near the patient. It takes a few minutes to do it. So exposure to the operator is pretty high. And that's another reason for reduced usage. And also, one needs to be well versed in the technology of using it. But critical care specialists as well as radiologists have used it, and it is useful. These are the normal lines, the A lines that are seen, these dense white lines that you're able to see in a normal chest using ultrasound. And this is what happens. The B lines, which are these lines which are outlined, which can be seen nicely. And these tell you that there's involvement of the lung parenchyma, and with improvement in consolidation, you get restitution of these normal A lines. However, these findings are not specific to COVID-19. They can be seen in any disease, but a return to normal A line profile from B line would suggest that the patient is improving. So this point of care ultrasound or POCUS has its own use. CT, we will discuss common imaging features on CT. We will talk about the role in initial diagnosis, role in prognostication, and then we will talk about evidence-based recommendations from Caring, our own research and development center, the Center for Advanced Research in Imaging, Neurosciences, and Genomics. In April, we published a systematic meta-analysis of CT features of COVID-19, lessons from radiology. We actually looked at a massive data set, which included 677 records identified through PubMed database searching, out of which 472 records were screened for relevance and 410 records were excluded. 59 full text articles were assessed for eligibility, and 10 full text articles were excluded with reasons given, and 49 studies were then included in our qualitative syntheses, and we did a quantitative synthesis and meta-analysis of these. And this is just the included studies, 47 of them, 49 of them, which were included. And this is how, we went about it. It was very, very exacting work looking at all of these. And now, these studies included over 4,145 patients, so over 4,000 patients, out of which about 3,600 had RT-PCR positive disease. And here you can see clinical features, the author, the date, the journal. This is the Lancet. And we actually found, and at that time, and this is April, when actually the Lancet and NEJM problem hadn't occurred. And I asked my group that how can you, not include the papers that have been published in the Lancet? And they said, sir, adequate data is not there. And because of that, these 10 full articles were, and you can see Lancet, you can see Radiology, Journal of Infectious Diseases, many, American Journal of Röntgenology. So I think that in the zeal to publish very quickly, a lot of times things were published which later had to be retracted. And this goes not only for these great journals like Lancet and NEJM, but for many other journals. Now, out of the 677 studies, these 49 were included, and diffuse bilateral ground glass opacities were most common finding at all stages of the disease, followed by consolidations and mixed density lesions. So commonest, ground glass opacity with very little character, followed by consolidation, and then there was a mixture of two. 78% of patients with RT-PCR confirmed COVID-19 infection had ground glass opacities, consolidation, or both. Now, the meta-analysis involved looking at different findings. We looked at ground glass opacities, consolidation, septal thickening, air trapping, reverse halo sign, nodules, effusion, fibrosis, mediastinal lymphadenopathy, crazy paving pattern, and others, what were known at that point of time. And these are the results. And these were very, very interesting. These had about 3,600 patients who had, ground glass, who had RT-PCR positive disease, and 500 plus who had negative disease. And if we look at no findings in RT-PCR positive on CT scan, only about 7% had no finding, whereas about 22% had no finding in non-COVID disease. So here, this is a chart which is comparing COVID findings on CT versus non-COVID findings on CT done during that same period. Ground glass opacities only were found in about 40% of COVID patients. But look at this number. Non-COVID patients also, in about 30%, there were ground glass opacities. And consolidation was about 22% in COVID and more, about 38% in non-COVID. So this slide I've put, and this was a learning that we had, that there is an overlap of findings on CT scan between COVID and non-COVID disease. Patients who are presenting as ILI or SARI, there is a significant overlap of COVID and non-COVID, and hence these reports and these anecdotal literature in lay as well as in medical literature which came out, which said that CT is the be-all and wherewithal of diagnosing COVID-19. I think one needs to look at this chart very clearly, that there is a significant overlap. Now, we will talk about that further as we go on. Now, if we look at the progression pathway of CT findings, it correlated very well with clinical findings. The initial patchy ground glass opacities and consolidations became diffuse lesions with septal thickening, air bronchograms in the advanced stage. And those that did worse, there was a diffuse whiteout of lungs needing ICU admissions, whereas on the other hand, there was complete resolution with or without residual fibrotic strips in those who recovered. And so the common imaging features were ground glass opacities, consolidation, mixed lesions, interlobular septal thickening, crazy paving pattern, and reticulations. And there were specific findings. The halo sign, which may not be seen all the time, but specific, reverse halo sign, spider web sign, pulmonary vessel engorgement, and vacuolar sign. And radiologists are very fond of making these signs. And so there were multiple of these that came about. The infrequent findings were architectural distortion, lymphadenopathy, and pleural effusion. Distribution of lesions, just as what we saw on the CT scan, they were frequently bilateral, they were peripheral, along the chest, near the chest wall, and subpleural. Most commonly, both lower lobes were involved. And in our meta-analysis of 3,600 odd RT-PCR positive patients, 7%, 235 patients had no findings on CT scans. And remember, these were patients who were admitted in hospital. Now, what are ground glass opacities? This is what they look like, featureless, just like ground glass. And most frequent can be seen with or without consolidations, and with or without seen in about 56% of patients. Consolidations were seen in 40%. In the initial stages, they can be unilateral, patchy, progressing to multifocal confluent lesions as the disease advances. And this is how you see it. Ground glass opacities proceeding on to consolidation, and then mixed lesions on the right side. This is ground glass on your left with some progression here, and these are mixed lesions, lesions with consolidation and ground glass opacities. Again, these are bilateral, peripheral, subpleural ground glass opacities with consolidations. The consolidation is denser than what we have ground glass opacities, and also you can see air bronchogram. Then we have the septal thickening, which you can see here as bright strands. And in the presence of ground glass opacities, which are less dense, you get that crazy paving pattern, what we get on our floor, crazy, jo floor pe karte hain. So this is what, and this is commonly seen in advanced stages of the disease, and usually after 1 week of onset of symptoms. This is, a patient diffuse bilateral ground glass opacities with focal consolidations, a mixed pattern with reticulations in the lower lobes. And you can also note this typical subpleural sparing, which is seen. And this is also seen in a fair number of patients as they progress. The other finding that we had was a vascular engorgement, prominence of pulmonary vessels in relation to the lesions, whether they are consolidation or ground glass opacities. So these prominent vasculature, prominent vessels, which are actually engorged, they are larger than what you expect at that point. And this is reported as one of the potential early predictors of someone who's going to go down. So there is help in prognosis of disease using this. Now, you see a crazy paving pattern here, and within that, what you can see are these engorged and dilated vascular channels. And this, these are cases where we need to be more aggressive with therapy, and CT can really give an insight into that. This is a reverse halo sign, which is a focal semicircular rounded area of consolidation around a less dense area of ground glass opacity. Now, the Radiological Society of North America recommends reporting the reverse halo sign as one of the typical findings of COVID-19. And you can see this here, dense and darker ground glass opacity here, dense consolidation. The same you can see here. This is a patient showing organizing pneumonia with air bronchogram, the typical air bronchogram that you can see, the same you can see here. So, I mean, the pattern and the distribution is rather typical, but otherwise, any ground glass opacity or any consolidation will look the same. They also talk of the vacuolar sign, which is a transparent shadow of less than 5 millimeter in length, which is observed within the lesion, this dark thing that you can see here. This is mixed ground glass opacities, consolidations with vacuoles within, which are large. You see another vacuole here, dark. And of course, we can see the air bronchograms very nicely. So what you see as hazy on X-ray, you see much better on CT. What you may miss on X-ray, you see better on CT. But it's much easier to do a X-ray because it's a portable bedside investigation. And for a CT scan, you have to bring the patient down to a CT machine. And so that is much tougher to do. Now, we all know now about the thrombotic response, the pulmonary thromboembolism. Thrombosis also an embolism in different parts of the body, which is now emerging as one of the hallmarks of COVID-19. And this can lead to pulmonary infarctions. And this is one area where a contrast enhanced CT scan will be done. As you can see here, this is a contrast enhanced CT scan, and you are able to see these, areas of pulmonary thromboembolism, the dark thrombi within the pulmonary vessels. This is one time. Otherwise, by and large, we always do only a plain CT scan. But where you suspect pulmonary thromboembolism, then a CT pulmonary angiogram will be done and contrast definitely has to be injected. Now, let's talk about the evolving role in initial diagnosis. During the early part of the outbreak, the hospitals in Wuhan, China, were extensively using CT scans for screening patients with symptoms suggestive of novel coronavirus infection. And some studies, as Dr. Agarwal also pointed out, showed better sensitivity for CT as compared to RT-PCR assay performed within 3 days of onset of symptoms. Arguments in favor of such extensive use of CT were RT-PCR tests of sputum or nasopharyngeal swabs required several days. In fact, these were the early days of the pandemic. RT-PCR was still evolving. The kits were very, very few, and it would take 5 to 6 days to get a report back. And that's when CT started getting used. And we know that thousands of additional cases were added to the cases of COVID-19 in Wuhan based on CT scan. The false negative rate at that time for picking up a lesion was just about 5% of RT-PCR, whereas CT could show the typical features. And even in asymptomatic, we know now that you can pick up the lesions, and you do RT-PCR later, it turns out to be positive. It is also a tool which, it just takes 10 seconds to do a CT scan of the chest and another 20 seconds to see whether there is any disease or not. Whereas RT-PCR still takes about 24 hours for you to get the reading, though, of course, CBNAT can give you a report in 30 minutes. And also, the new antigen, rapid antigen point of care test is also able to give you a report in about 25, 30 minutes. But the current sensitivity of the rapid antigen test as validated by ICMR is only 55%. So still 1 in 2 cases will get missed. And so because of that, RT-PCR still remains the gold standard. All those patients who are found to be negative on this rapid antigen test should undergo RT-PCR test. That is the recommendation of ICMR. Otherwise, many positive cases who are labeled as false negative will go around and spread the disease. And so that speed of CT is still something which is a plus. And should it be used to screen patients? The societies around the world don't agree on that. Now, concerns were raised by several radiology and thoracic societies against such sweeping conclusions of the superiority of CT for screening of COVID-19, for screening in a population. Several reports that confirmed normal chest CT scans cannot exclude the diagnosis of COVID-19, especially for patients with early onset of symptoms. And studies in our own review showed that CT scans were normal in 11 to over 50% confirmed admitted cases during the early course of the disease, and showed findings only later on. And also, as we saw in that graph which I showed, 34% of patients CT, which was labeled as COVID-19 by radiologists who were reporting on such cases and who had knowledge of the disease, were false positive. So the overlap is great, and we may end up calling many patients as COVID-19 if we use CT as a screening. But RT-PCR would still need to be done to confirm the diagnosis. But as the sensitivity of RT-PCR tests improved, the focus of studies shifted of use of CT from diagnosis. In fact, in the end of February, the Chinese government and the Chinese authorities actually decided that they would not use CT for diagnosis of COVID-19 and only use RT-PCR. But CT gained prominence as a diagnostic tool, as a prognostication test. A recent study from Italy reported perilesional pulmonary vessel enlargement, as I showed you, in areas of lung infiltrates could be an early predictor of lung impairment and of a patient going downhill. In our review, mediastinal lymphadenopathy and pleural effusion were found very infrequently, 1 to 2% of cases in COVID-19, though when found, the prognosis is worse. So the disease has a much worse course if a patient with COVID-19 has pleural effusion or lymphadenopathy. And this, it's thought, might reflect the viral load and virulence of COVID-19 disease. Now, these are serial CT scans in a 35-year-old woman with COVID-19 pneumonia, and you can see ground glass opacities progressing to pneumonia and then becoming denser. This is, becoming denser here, organizing pneumonia, and then, improvement, and maybe left with some scars if we were to do a CT after this. There is also a CT severity score, which we talk about. And for this correlates CT with the severity of disease. Both lungs are divided into 6 zones, 3 in each lung. Zone 1 is apex to carina, zone 2 is carina to inferior pulmonary vein, and zone 3 is below the inferior pulmonary vein. And the lung opacities in all the 6 lung zones are scored. And overall CT score was the summation of scores from all 6 lung zones, and the maximum score possible was 24. So this also, to some extent, correlates with the clinical disease. 1 to 25% is the score is 1, up to 50% score is 2, up to 75% 3, and more than 75% score is 4. So 4, 6 are 24, and that's how the CT severity score is done. And also, it is seen, you have the type L patients, as they were called in Italy, and the type H patients. Type L patients have less severe zonal involvement, and they do well on non-invasive ventilation. And type H patients have more severe zonal involvement, and they may require intubation, PEEP, prone position ventilation. And hence, CT can also, of course, now we know that much fewer patients require intubation and ventilatory support than we knew in the early days of the disease. But CT can help you in determining which patients will do better in the prone position or the recumbent position, and which may worsen and go and may need intubation. Now, RSNA, the Radiology Society of North America, gave a statement on CT scan reporting in COVID-19 referrals: typical appearance, how to report it, indeterminate appearance, atypical appearance, and no pneumonia. And this is what is generally used as way that we report this. The RSNA reporting guidelines, again, commonly reported imaging features of greater specificity for COVID-19 pneumonia, and the guidelines, and we will go forward. These guidelines are there. Our experience with CT scans for COVID, we have seen all combinations of clinical and radiological presentations. In symptomatic patients, typical chest findings, atypical, RT-PCR positivity, all of these, there is a lot of overlap between them. This is a patient who is symptomatic, CT positive, and RT-PCR positive. Now here you see these subpleural lesions, small lesions in both the lung fields, a very early lesion seen here. The CT is very easy. So this is symptomatic, CT positive, RT-PCR positive. This is a patient who's asymptomatic, but had exposure, chest CT positive, just look at this tiny little area of ground glass haze here, and RT-PCR negative. So this is a patient who is RT-PCR negative, asymptomatic, history of contact, chest CT positive, RT-PCR negative. We still don't know. Should we actually isolate this patient? Is this something else? We have repeated RT-PCR in some of these patients and they stay negative. What we have done for our own healthcare workers is we've sent them for isolation for 7 days. This is symptomatic, chest CT positive, and 4 times RT-PCR done is negative. This you can see, this is a CT done on 22nd when the patient just showed very mild symptoms. There was no breathlessness. The oxygen saturation was 97, 98. He happens to be one of our own radiologists. On 27th, he actually developed breathlessness, brought to the hospital. The lung lesion had increased and we found 1 or 2 fresh lung lesions. Now, over the last 9 days that he's been admitted, we've done RT-PCR 4 times, but he's received steroids, he's received remdesivir, even though RT-PCR continued to be negative. And luckily today, he's been discharged and has gone back home. So we still don't know what we were dealing with. As per definition, this cannot be labeled as COVID-19 because RT-PCR has been negative and repeatedly so, but then it has been treated empirically as COVID-19. Now, we are also working along with the Indian government and some of our other partners, CSIR, in developing an AI tool for being able to diagnose COVID-19 on a chest X-ray. And this has been built and is hosted on a publicly accessible portal called cove.base, and anyone can use it. And this is how it shows the possibility, what is the probability in percentage terms of a chest X-ray being normal, abnormal, and if it's abnormal, what is the probability that one is dealing with COVID-19. This is an ongoing project that we have, but this is something that we are doing pro bono, and this is something that will be available to anyone around the world to use to help in their own cases, in their own patients. And this is how it will outline the abnormality. There may be heat maps, there may be these boxes that may be drawn, and this is freely available for anyone to use. The cove.base, this is Central Clinical Data Repository for COVID-19 patients across India. And this is hosted on this website, which is on the ICMR, hosted on the ICMR website. And this is work that we've done, caring along with IGIB, along with our other partners, Teleradiology Solutions. We've all worked together to build this, and this will keep getting better over time. Now, a word about extra-thoracic COVID manifestations. And we know that it can cause encephalopathy, and these are the typical lesions. generally bilaterally symmetrical, though they may be asymmetrical, and this may present as acute hemorrhagic necrotizing encephalopathy. And this is how the lesions look. There may be multi-system inflammatory syndrome, which may be associated with COVID-19, and the constellation of findings includes airway inflammation, development of pulmonary edema on thoracic imaging, coronary artery aneurysms, extensive right iliac fossa inflammatory changes may be seen on abdominal imaging, and awareness of this emerging condition and multi-organ involvement will aid in assessment of these complex abnormalities. This is a comparison of radiological findings in children with acute COVID-19 respiratory infection, Kawasaki disease, and multi-system inflammatory syndrome in children associated with COVID-19, and it's all available in literature. This is a medium-sized aneurysmal dilatation that one is seeing of the left main artery, and a large aneurysm. This is the left main that you can see, and also of the proximal LAD. And this is also something that we are seeing. Here you're seeing gallbladder wall edema, an extensive thickening of the cecal wall, and free fluid mesenteric lymph nodes that are seen. This is a splenic infarct, hypercoagulable state leading to thrombosis. And so this is a disease which thankfully is more or less limited in its severity to the chest. But as we see more and more patients, we know that it can be present in other disease conditions. This is cardiac MRI for 4 children with clinical diagnosis of acute myocarditis in the setting of COVID-19 related Kawasaki-like symptoms. And here again, MRI can be used to look at the myocarditis itself and to know whether there is any superadded ischemic disease also, which is present as a part of involvement in COVID-19. Now, I will now take you through evidence-based recommendations that we have for use. CT should not be used for screening or initial diagnosis of COVID-19. It's not to be used as a diagnostic tool. The evidence, at least 7% of patients had no findings of CT scans in early disease, and CT scan findings were reported as typical of COVID-19 by radiologists in 34% of patients with non-COVID pneumonia, false positive. Then CT can be used to identify early markers for lung impairment in symptomatic patients with RT-PCR proven COVID-19. The evidence is the prominent pulmonary vessels near pulmonary lesion or microvascular dilatation has been shown to have worse clinical course, and pleural effusion or lymphadenopathy have been again associated with a high viral load. CT can be used for patients with non-resolving symptoms to study progression of disease. Evidence, there is clear progression pathway of CT findings correlating with clinical findings. I showed you a few cases. And initial patchy ground glass opacities and consolidation progress to diffuse lesions with septal thickening, air bronchograms in advanced stages. And further course can either be diffuse whiteout, where patients need ICU admission, or complete resolution with or without residual fibrotic strips. And we saw examples of that. CT has limited role in stable pediatric patients, as up to 60% of pediatric patients in our meta-analysis had ground glass opacities and consolidations on CT, but all of them showed complete resolution of the disease. So use of CT in the pediatric age group with COVID-19 should be rather the exception than the rule. Another recommendation, X-ray should not be performed first on patients with history of dry cough and fever, and high pretest probability of COVID-19. So let's not, if someone comes with the, dry cough, fever, some physicians tend to get an X-ray chest first. I think in this pandemic, and with the way we have the disease in our country, RT-PCR should be done first to know whether a patient has COVID or not, and X-ray only later when required as per the clinical circumstances of the case. X-ray should not be used as a screening modality for COVID-19. Now, we should consider every patient coming to the radiology department or our radiology centers with any respiratory ailment, minor or major, especially fever, cough, breathlessness, as potential COVID-19 and handle the patient accordingly, taking all precautions. Patients coming for X-ray chest, PNS, CT, ultrasound to the radiology department have to be handled very carefully, quickly, with no mixing with other patients and maintaining strict norms of social distancing. We should bring the patient into radiology department after all logistics, formalities, paperwork have been completed outside, and our scanning room is empty and our scanning machine is ready. Our aim should be to have zero waiting time, fast in, fast out. Sanitization of the equipment to be done before taking the next patient as per guidelines, and where there are 2 CT scanners available in a hospital, dedicate one for COVID-19 patients. A dedicated portable X-ray should be used in the ICU and in the wards, and teleradiology to be preferred for reporting to minimize exposure to radiologists. Now, in the OPD setting of fever clinic, a patient who comes with respiratory symptoms, fever, cough, breathlessness, again, should not be straight away sent for chest X-ray, as a potential COVID patient may end up infecting radiology staff and other non-COVID patients. After initial clinical examination, if the patient is not very sick and not requiring admission, it is recommended that a hemogram may be done. If you suspect that it may be COVID, then RT-PCR is now widely available in all cities in India, and this may be performed via nasal swab and oropharyngeal swab to confirm the diagnosis. Chest X-ray is recommended in OPD setting or fever clinic in those patients who come with moderate to severe symptoms where possibility of a positive chest X-ray is high. Dedicated portable X-ray machine should be used for fever clinics. Keep one X-ray machine there to be used where logistically possible. And there are certain specific features of COVID-19 on chest X-ray, which we've seen, but there is still significant overlap. And we need to remember that. CT is not recommended for initial diagnosis of COVID-19, but could be used as a triaging tool to determine lung involvement, extent and severity of disease, and to guide future line of treatment. So this is where in the 2 months, I think there is a little shift in our thinking that CT may be used initially also, because that may help you in determining your line of management. Is the patient to be admitted into hospital? Of course, you cannot lose sight of fever, of his clinical condition, of the oxygen saturation, which are very, very important. Falling oxygen saturation, as Dr. K.K. Agarwal only taught us, by 5 from 98 to 93, or going below 93 may be there, but a CT may help a clinician. And we are finding increasingly dependence of clinicians on a CT scan for this triaging, to use it as a triaging tool. In IPD, X-ray for all confirmed COVID-19 patients or those whose reports are awaited should be done at point of care using portable X-ray and all precautions, not in the main radiology department. The portable X-ray should be placed in the ICU at all times and should be sanitized periodically. where X-rays are done in the ICU, and this is important, attempt should be made that all those requiring an X-ray should be done at one time, so that entry exit of the X-ray technician is minimal. It should not be that there are 15 patients, you call the X-ray technician in the morning at 9, then call him again at 10 for another patient, at 10:30 for another. I think in the morning round you decide, and then all those who require X-ray should be done one after the other, unless there is some emergency for which you need to do in between. Use of CT should be when essential and when it is likely to impact on patient management. And we know that it is better than X-ray for showing typical lesions and temporal change. CT should be performed when pulmonary thromboembolism is suspected, and CT machines need sanitization as per guidelines. Point of care ultrasound may be performed in specific clinical settings in the ICU to study temporal evolution of the disease, and CT head oblique MRI may be used in COVID-19 patients who develop encephalopathy. And in a diagnostic center, I end with this slide, generally no clinician is available, and radiologist has to take the final call on whether to do the scan, not do the scan. A suspected COVID patient can't be sent to a fever clinic or cannot be isolated in a separate area, and must be sent to a COVID facility in case COVID is highly suspected. Asymptomatic, pre-symptomatic patients, we should reduce mixing and universal masking, trying for zero waiting, and many times making the patient wait in his own car is what we do. In asymptomatic healthcare workers, it's a real dilemma of diagnosis since manpower is also limited. In symptomatic patients with negative RT-PCR report, is CT the answer? We found in some of our own workers that CT was positive, RT-PCR also came positive. In fact, in 10% of our workers in one center where we did low-dose CT scanning, just in asymptomatic patients, 10% showed up lesions on CT, out of which 5% were RT-PCR positive. So this is something which is still open to debate. Should we create a dedicated CT facility? Actually, since we have 5 standalone centers, we've converted one into a dedicated facility for OPD patients of COVID-19 for CT scan, because it's very difficult for patients to get a CT scan done today. Many hospitals want them to get admitted. Many take them through their emergency, and so they have to get registered. They have to pay money in the emergency and then pay for the CT scan. So this is another. And should a typical X-ray CT picture be reported as positive as possible COVID or just as viral pneumonia? What we do, we report it as viral pneumonia. Don't use the COVID word, but we pick up the phone and talk to the clinician and tell him that this is likely to be COVID, and kindly, because we find these incidentally on CT as well as X-ray, where it's not suspected, and we warn the physician that this could be possible COVID, so you must be careful and get a RT-PCR test done. Thank you so much for your attention, and please stay safe. Thank you.
Thank you, Dr. Mahajan, for a wonderful and exhaustive presentation. I'll do some quick rapid fire questions, and then it will be open for everybody to ask questions. Normally we finish in 1 hour, but we will extend it by around 20 minutes, today's discussion. And the first thing is that we would like to know, number one is, because now we are preferring more of a home treatment. And we say that up to 5 liters of oxygen, when it is a low flow oxygen, even high flow oxygen machines are available, unless a patient requires a high flow nasal cannula or a ventilator, he can be managed at home. Can we find out a cutoff? These are the patients who can be managed at home in terms of radiology. We have clinical parameters. We have clinical parameters with us, but do we have a cutoff that at this point, he is going to end up into a ventilator?
I think in the mild cases, because it's mild cases that are, being treated at home. And in the mild cases, I think, what we are finding, and our pulmonologist and physician friends are also open to this suggestion. When the mild starts, deteriorating, when there's someone who's on, say, 98, 97, and then comes down to 95, 94, and that's when you start thinking, is he going to worsen? Those are patients when probably they need to go to a hospital. And when they come to the hospital, more and more we are seeing that a CT scan is also being done before they get admitted, which is helping the pulmonologist, which is helping the physician to determine. Because if there are multiple lesions, and many times you find that this, it has happened for our own healthcare workers. And so we know, and we have sequential follow up also, that he was doing well 5 days at home. And then suddenly, he starts feeling breathless, that starts feeling different from what he was for 5 days. And then when we bring him in and we do, and these are RT-PCR positive COVID-19, and then we bring him in, do a CT scan, we find 5, 6 small scattered lesions, and that actually is helping the pulmonologist decide that no, I need to admit this patient in the ward, watch him. Maybe this may be the time when they may give steroids. This is the time early on when they may start antiviral therapy. And so we are finding this new indication, where it is helping in determining. But I think someone who's stable at home and remains stable throughout the illness, I don't think there is a role for imaging in such a patient. The role will come when when his status changes. I hope I've
So
answered your
I
question.
want to add, because most of your data presented is for a hospitalized patients. I tell you the observations which I have got. At the moment, I have a data available of over 2,000 patients with me. And the data shows if you have a loss of smell and loss of taste, you don't end up into a seriousness. You can very well be treated at home. That will take care of a large segment of the society. 2, if you have diarrhea as a symptom, 80% of them are women, almost 90% of them are women, and they also don't end up into a seriousness. 3rd, in children, the commonest presentation is a rash. It's a non-pulmonary presentation. The rash recovers in 3 to 4 days' time. 4th, there may be isolated cases presenting only as headache or as a subconjunctival hemorrhage. 3rd or 4th day, the COVID test is positive. They don't get any other illness. Another group will be a patient who says, gale mein kuch atka hua hai, and that's it. They only develop gale mein kuch atka hua hai. They have small degree of smaller airway obstruction. You give them inhalers, they recover, and they become all right by that time. So we are now looking for so we said post-COVID is 9 days. After 9 days, you are a post-COVID residual inflammatory or immunological response or a residual pneumonia, which you need to treat. In the first 9 days, I'd say day 3, day 4, day 5. On day 3, day 4, and day 5, if you have a chest heaviness or a chest congestion, which we presume it to be the first sign of pneumonia, get your HRCT done. If HRCT at that time shows a more than 2 ground glass appearance, or if you have exertional anoxia, hypoxia of a fall of more than 5, or if you have exertional tachycardia, which is unproportionate to fever, shoot remdesivir or favipiravir with start dexamethasone 6 milligram daily, give a shot of low molecular weight heparin, then talk to the relations about admission. That's what till now, after discussion with so many people, we have been able to get. So my idea is on that day 3, can we have a number on CT which can tell me, is it like, because most of the CT mild cases may recover at home. We knew that all our life we have seen OPD management of mild pneumonia and viral pneumonias, because we used to say treat viral pneumonias at home. But here I'm talking about it on third day. Even if I have, do I have take one single opacity, two opacities, three opacities as a marker? Because when I say remdesivir, low molecular weight heparin, I'm talking about a cost versus forget about it. Nothing to be done. Just give them dexamethasone and don't give them anything else. So at what level I decide about aggressive treatment of either tocilizumab, which is costly. Now it is costing 90,000 in Delhi, which the injection is less than 10,000. In black market, it is available at 90,000. Remdesivir in black market is costing 3 lakh for the whole treatment. So therefore, now what is happening is everybody is afraid. Pneumonia means give them IV remdesivir, tocilizumab. So what I'm trying to find out is, can we find out a marker? Here, you can take a chance and just give them a low molecular weight heparin or give them along with the dexamethasone. You don't need to give them aggressive costly medicines. So here, can we have a marker? That's my interest, is because in pulmonary manifestation is the only patient of seriousity. Non-pulmonary manifestations, we don't care. They all are going to become all right.
I think I will not be able to answer that, because we will have to do a study on this, which to the best of my knowledge hasn't been done, because these are all mild patients.
Agreed.
And mild, when will they become? Maybe day 5 or day 6, maybe, a time frame when we may be able to better triage them. But I have friends who say, no, do CT for every patient irrespective, and we can differentiate those who are going to worsen and those who are not. But these are all anecdotal and personal experiences. Till such time we actually take up, maybe do CT for 500 people, and we've done for 60 of our healthcare workers, and we are following them up. But I think this is an answer that I don't have.
So for me, it is 380th hour of discussions with people all across the world, and continuously 6 hours a day I'm interacting. I have come back to a conclusion where everybody agrees is day 4. Be careful for day 4. Day 3 is the earliest. Day 5 is, by day 5 you have the symptoms, but we have been able to come out is that if you cross the day 4, that means day 3, day 4, and day 5, then it's a milder disease. Most of the people will get complicated by day 5. So if you cross 5 days, then probably it's a mild disease. Progression will occur by day 5. I mean, it will never be a law. It is always will be a consensus. But therefore, we say if a patient comes on day 7, 8, and 9, then probably he's having a thrombotic complication, not a pneumonia complication. Then it is a
we can do a randomized controlled trial on this.
Agreed. But I'm only trying to say is at this moment, there is no time for randomized control trial. We need guesstimates. We need to take certain decisions with that.
See, if you were to ask me, I can speak for myself. What if I were to have it?
Agreed. What will you do?
I will 100% do a CT.
CT. On what day?
I would do it even, we found in our own cases, 10% asymptomatic.
Agreed. I said asymptomatic.
Asymptomatic. In 10% we found lung lesions. Okay. And out of them, half were COVID, half were not.
That's okay.
And these were all asymptomatic.
That is acceptable, Harsh. But what I am asking is, can we have an asymptomatic person developing happy hypoxia out of them? Because when we say asymptomatic, I've been working on the word asymptomatic for the last 2 weeks. I've yet to find more than 2% of the cases who are actually asymptomatic. If you really find out, he says, हाँ वो एक डायरिया तो हुआ था. If you say नहीं वो तो 1 घंटे के लिए गले में खराश आई थी. They actually are all asymptomatic. True asymptomatic is very, very, very rare. Some symptoms lasting for 2 hours, 4 hours, Another important thing is in women, during menstruation, the symptoms disappear. So if they happen to have, they will have pain on day 1, second day they have menstruation. Then for 4 days, their symptoms will disappear. Day 5, they will become serious. And then they will say that this is my onset, because during menstruation, symptoms are disappearing. That's a constant observation of mine. So there are
but I would say I would, if my symptoms are mild and suppose I'm diagnosed RT-PCR positive today,
you will go ahead.
I'll go ahead and do it today itself.
Okay.
And we are doing very low dose CT. We use same dose as is used for cancer screening in smokers. So it's very low dose CT. But I think for a patient, I would say day 3 may then be the ideal, so that you can start whatever preemptive treatment can be started day 4.
I agree with you, day 3, and I normally have compromised it to day 4 because some says 3, some says 5. So therefore, I said day 3 or 4. And by 4th day, if you don't have a complicated pneumonia, chances are that you have a mild disease and you will be able to all right. So I hand it over to Dr. Ashokan. I sign off from my side.
Thank you.
Sir, may
Thank
I
you,
ask
sir.
some questions?
Maybe one. We are delayed.
Yeah.
Yes, Dr. Kalra.
Only one question, sir.
Sir.
I wanted to know, sir, how common you have seen flare-up of underlying tuberculosis in case of COVID, because they are given steroids also.
Sir, we've had 1 or 2 patients who had underlying tuberculosis and also had COVID. Since we see them only once and scan them only once, and these were active cases of tuberculosis. These were not tuberculosis that had been already treated and completely healed. So, and these are 2 cases that we've had where these 2 lesions were coexisting.
One more comment with permission of the chair, sir. Like we have BI-RADS for the breast imaging,
we have CORADs,
for the prostate. Do we have COVID imaging?
Yes, we have CORADs, sir. But that is for the radiologists. So we talk about that in the radiology. There is CORADs. Now radiologists have become very smart, sir. Because they feel that clinicians are equally able to diagnose. So we create something so that.
Thank you,
sir. I just want to add, Harshish, that how do we differentiate in monsoon season when we have a patient coming on ultrasound, and if we had a GB gallbladder thickening and a peri-gallbladder fluid, we used to say dengue, and now we say it's COVID also. So how do we differentiate?
Yes, but these are still anecdotal cases. These are, but then it's like any viral infection. It can affect anywhere.
Okay. Dr. Ashokan, can you?
Yes, sir. Sir, there's the best classical presentation and classical discussion that has happened. It has enlightened us so much. It's really a tool for the clinicians. And I also appreciate the intellectual honesty of Dr. Harsh Mahajan. When he sometimes says that I really do not know, I think he's being extremely modest. I'm very grateful on behalf of Indian Medical Association that he chose to come on this platform, because this will be broadcast and put up in the website of IMA for all its members. It's really so generous and magnanimous of him to allot time for Indian Medical Association. Thank you, sir. I hand it over to Dr. KK to close the meeting.
Thank you, sir. I am as much a part of IMA.
Yes, Dr. Ramesh Datta to propose a vote of thanks.
Thank you, Dr. Kar. On behalf of Indian Medical Association, I am thankful to Dr. R.V. Ashokan for organizing this webinar on imaging in COVID-19 today. And at the same time, my special thanks to Padam Shri Dr. Harsh Mahajan, who has enlightened us about the latest imaging techniques and their necessity of doing these tests in COVID-19 disease. My special thanks to our anchor, Dr. K.K. Agarwal, who is the chairman of SAMAU and past president of Indian Medical Association. And he is my guru also because every week I am learning something or the other from.
Thank you, sir.
And I thank Dr. Sanchita and Dr. Jay Krishnan for participating in this discussion, and all the other participants who have today joined us. And I think today they are in a large number, and they have really got something or the other as far as the imaging techniques are concerned. My thanks to the our staff who is working behind the scene and behind the curtain to make this webinar a success. With these words, I thank all the participants, and my special thanks to Dr. Harsh Mahajan, who has really taught us wonderful things today. I am really very much enlightened by his talk. Thank you very much, sir. With these words, I thank all the participants and uh, wish them good luck.
Thank you.
Thank you. The meeting is closed.